Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you all to my interview with two of the authors of an important and interesting article from the April 2006 edition of the Journal of Rheumatology. Today, I will be speaking with Dr. Marius Smits and Ms. Elaine Renet from the Department of Rheumatology, Maastricht University Medical Center and Care and Public Health Research Institute, Maastricht University, Maastricht, the Netherlands, on behalf of all the authors of the featured article titled Predictive Value of Severe Symptoms for Residual Disease After Transitioning from High to Low Disease Activity in Axial Spondyloarthritis, a longitudinal study. And I want to thank you both for taking the time to speak to me and our listeners on behalf of all the authors of your paper and discuss the findings of your important paper on the importance of patient symptoms when considering low disease activity or remission in patients with axial spondyloarthritis. So with that, shall we begin? Okay. So can you please explain the rationale or hypothesis that led you to do this study?
Yes, definitely, I can make a start. I'd first like to take this opportunity to thank you as well as the journal on behalf of our entire team for recognizing our work, also for the opportunity today to further elaborate on this study. And to your question on the rationale, what we have witnessed in recent years is an expansion of the treatment modalities which are available for the management of patients with axial SPA. And this has contributed as well in clinical practice to a growing proportion of our patients who are able to attain the stipulated treatment goals in our current management recommendations, namely inactive disease or low disease activity. But at the same time, what we see in clinical practice is that there remains a considerable proportion of patients who, despite achieving this treatment goal, continue to experience clinically relevant signs or symptoms of the disease. And this is a phenomenon that has been described in literature as residual disease. Now, residual disease is still quite a relatively new topic in axial SPA, but it is one that is also already evidently significant, considering the potential impact that persistent signs or symptoms of disease can have on patients, and specifically also their quality of life. Previous studies have primarily focused on the prevalence of residual disease as well as factors that are associated with it. And so as a stepping stone towards gaining a better understanding of residual disease and expanding our knowledge on this topic, we aimed through this study to also explore other contextual factors surrounding residual disease in more depth, including possible predictive factors to enhance our approach in the future to managing axial SPA more holistically. The hypothesis in this study specifically that we formed was that the magnitude of disease activity or symptom severity that is experienced by a patient while they are still in a high disease activity state might have prognostic significance on the outcomes experienced by the patient after they reach the treatment target of inactive disease or low disease activity. And the relation between these potential predictors and the outcomes was what we aim to investigate through this longitudinal analysis, which we will elaborate further on today.
Thank you. Anything else? Okay, so with that, let's move on to who you studied, the population, the time period, the outcome measures. And go ahead.
I will gladly elaborate on this. We used data from SPA-net, which was a disease-specific web-based registry for patients with SPA in the Netherlands. So patients who had SPA and who attended either the academic hospital in Maastricht or the large general hospital in Enschede, which are two centers in distinct areas of the Netherlands, they were consecutively included as part of routine care between 2016 and 2023. And for our study specifically, we included patients with axial SPA who had an observation both in a high disease activity state with a consecutive follow-up within 12 months where they reached an inactive disease or a low disease activity state. Our predictors were as follows. Firstly, we looked at a very high disease activity status defined with the ASDAS, which is the preferred outcome measure for assessing disease activity in axial SPA. And secondly, we looked at severe symptoms while at the high disease activity time point. And we defined these severe symptoms as a score of at least 6 out of 10 for fatigue, back pain, and limitations in physical function, according to the BOSFI. And these specific symptoms were chosen because these were amongst the most reported in axial SPA and have consistently been rated as especially important by patients in previous literature. The outcome that we investigated was either patient experienced or objective residual disease after achieving an inactive disease or a low disease activity state. Patient experienced residual disease was defined as a score of at least 4 out of 10 for the symptoms, fatigue, back pain, and reduced physical functioning. And our definition of objective residual disease was the presence of either active peripheral manifestations, active psoriasis, an elevated serum inflammatory biomarker, or a physician global assessment indicating active disease.
Thank you. And just a feel for what percentage of patients came from each center?
Sorry?
From each, you had 2 centers. Just was it evenly divided? Just for a feel for the audience of what percentage came from each, approximately.
Well, we know that patients who participated in SPA-NET, they are representative of the overall SPA cohort in both Maastricht and Enschede. However, we cannot really provide an exact proportion of patients per center because of the dynamic nature of this patient population in both hospitals.
I'm sorry, I think maybe, but you do know how many patients were entered from each hospital? That's really my question. What, like, was it 50-50, 60-40? Just so we know if there was a center bias, was really my question.
I can elaborate on that a little bit more. The primary center in which SPA-NET was conducted, that was in Maastricht.
Okay.
Due to missing data, not all patients who were included in the SPA-NET registry were eventually included in this analysis. However, taking into account that the primary center in which SPA-NET was originally developed, there was a higher representation from patients from the Maastricht Center, so representing an academic setting in comparison to the peripheral or the general hospital setting, which was in Enschede.
Okay, thank you. Very helpful. So now we'll go for the results, if you don't mind.
So I'll gladly elaborate on the results which we found in this study. To start with a brief overview of the patients which we included in this particular analysis from SPA-NET, after applying the inclusion criteria which were described by my colleague, we included 133 patients with the diagnosis of axial SPA in the present study. And to now take you through the results themselves in a chronological order, we start at the time point of high disease activity, at which point in time 12% of our included patients had a very high disease activity status according to the ASDAS, which was the first predictor which we investigated, and 81%, so the vast majority, had at least one severe symptom at this time point, which was the second predictor which we then looked at. The symptom that was the most common amongst those reporting severe symptoms was fatigue, which affected 64% of our patients at the time point of high disease activity. We then move on to the time point of inactive disease or low disease activity, at which point in time we found, as expected, and also similar to previous literature on this topic, a high prevalence of residual disease, with 71% of our patients reporting the patient-experienced form of residual disease, and a lower percentage, 54%, experiencing the objective form. And these were defined according to the definitions which we previously discussed as well. Looking specifically at the patient-experienced form of residual disease, the most prevalent symptom that indicated residual disease was once again fatigue, which 59% of our patients experienced. However, it is important to note as well that patients often presented with several symptoms simultaneously. If we then look at the main goal of this study, the relationship between the predictors and the outcomes which we investigated, we saw that very high disease activity at the time point of high disease activity was not predictive of either form of residual disease. But what we did observe was that severe symptoms was associated with patient-experienced residual disease after achieving an inactive disease or low disease activity state. There was no association, however, with the objective form of residual disease. and to give you an impression as well of the magnitude of the associations that we found between severe symptoms and patient-experienced residual disease at the later time point, we found an odds ratio of approximately 5, indicating greater odds of patient-experienced residual disease among those who had at least one severe symptom when they were still at the time point of high disease activity. Furthermore, what we saw was a predicted probability of residual disease of 78% in those who had severe symptoms prior, and 43% in those who did not have severe symptoms prior. So altogether, what we saw in our results was that there's a higher likelihood of having patient-experienced residual disease after achieving the inactive disease or low disease activity treatment target among those who previously had severe symptoms in comparison to those who did not.
Thank you. So I noticed that you talking about severe symptoms, you had 2 different cutoffs used in your analysis. Please explain what the cutoffs were and why you did both analyses.
I can elaborate on this.
Okay.
Well, the typical threshold of symptoms also for the BUSDI have been set at a score of 4 out of 10 at least to best distinguish between fulfillment and non-fulfillment of patient acceptable symptom state. And this was then also the definition of residual disease. However, when we look at severe symptoms, our predictor, we specifically wanted to detect an especially high disease burden, and therefore we set our cutoff for the definition of severe symptoms in high disease activity as a score of at least 6 out of 10. However, as there are currently no validated cutoffs in the context of severe symptoms, we also conducted a sensitivity analysis where we used a cutoff of at least 8 out of 10. Our decision to use this cutoff of at least 8 out of 10 in the sensitivity analysis was on the basis of how so-called extreme disease burden has been described in previous studies. And eventually, also by applying this alternative cutoff value, we were able to test the robustness of our initial findings. And in this sensitivity analysis, where we used this higher cutoff value of 8 out of 10, we observed comparable effect sizes as with our initial analysis, where we used a cutoff value of 6 out of 10 in the definition of severe symptoms, which indicates that also extreme symptom severity, but also high symptom severity in a high disease activity state, they are both associated with patient-experienced residual disease. So to conclude, the cutoffs were arbitrary. However, they were intended to detect meaningful differences in symptom severity, and they were grounded in previous literature as well.
Thank you. Very good. Want to add anything, ma'am? We good?
I think that's quite clear for now.
Okay.
Yeah.
So would you, now moving on, a very good explanation, please outline what you believe are the strengths first. And we all have some weaknesses. We often admit that in every study.
I will gladly do so.
Okay.
The main strengths of our study are the longitudinal design, but also the broad perspective that we took on residual disease. So by using real-world longitudinal data from both a university hospital, but also a general hospital, they made our findings more generalizable to a broader patient population in the Netherlands as well. And additionally, we had a very broad perspective on residual disease, where we considered both patient-experienced but also objective residual disease. And this offered a comprehensive understanding of the effect that severe symptoms and a very high disease activity have on the risk of future residual disease and also its specific manifestations. However, our main limitations, they lie in the uncertainty of actually identifying residual disease. So firstly, the ASDAS, which is used to assess disease activity, it relies largely on patient-reported outcomes, and it does not account for example, MRI activity or extramusculoskeletal manifestations. And therefore, potentially, patients who are in an inactive disease or low disease activity based on this ASDAS may still have active disease which is not captured by the score. So whether these patients then have true residual disease or whether they have uncaptured disease activity, it remains unclear. Looking from the other side, the absence of objective measures of disease in SPA-NET may also have led to us not being able to detect objective residual disease. Secondly, when looking at the symptom side of residual disease, the patient-experienced residual disease, some symptoms that may currently be captured as residual disease may also stem from, for example, comorbidities such as pain sensitization. So taking into account accurately identifying residual disease, it remains challenging.
Thank you. So now that we've gone over findings in the study, how do you find it should be incorporated into clinical daily practice and the management of patients with axial spondyloarthritis, obviously to improve patient experience?
So I can elaborate a bit further on that. And it is a great question because as we now have expanded knowledge to support that severe symptoms are potentially predictive of patient-experienced residual disease, the next challenge is, of course, incorporating this knowledge into the way that we approach our patients in clinical practice. Naturally, the ultimate goal is to be able to manage residual disease adequately in our patients who are affected or even prevented in the first place. But for this, further research is first necessary to explore specific management strategies tailored to residual disease. But nonetheless, what we are able to contribute already based on the results of the present study is hopefully an increased awareness on the phenomenon of residual disease, once again, as it is still quite a novel concept, both in the research and clinical settings. We hope that this will spread the knowledge and awareness about this phenomenon, both to rheumatologists and patients, and already enable conversations in clinical practice in the consultation room on aspects such as expectation management to helpfully help patients cope better with their symptoms, to be able to have a better idea of what to expect in the time to come, and hopefully thereby improve treatment outcomes. Based on our findings as well, rheumatologists might already be able to better anticipate residual disease in their patients with axial SPA. So in the case of the findings of our study, being more alert to severe symptoms, to be able to mitigate the impact of potential residual disease from early on in the treatment trajectory. So it is important that stakeholders stay alert on the presence of potential predictive factors, all the way from the time of diagnosis, so as early as possible, to enable more holistic care pathways that might also involve, for example, multidisciplinary teams, ancillary healthcare professionals, to contribute as well to the treatment process, to offer better support to patients who need it in a timely manner. And in this way, we hope that patients will not only be able to achieve biological remission, as we see in the clinic through increased or expanded treatment modalities, have led to patients being able to achieve lower ASTA scores corresponding to lower disease activity. But we also hope that the findings and the research that is being conducted on residual disease will also help patients to achieve persistent symptom remission in hopes of improving particularly health-related quality of life as we look to the future of patient care in rheumatology.
Thank you. Very in-depth explanation, and hopefully it will change practice. And I think one of the things I took away is also how hard in axial SpA, as in most rheumatic diseases, that fatigue is a huge symptom which may be totally disconnected from the objective examination that physicians do and how we assess as a physician disease activity versus the patient experience. And to me, that's going to be the future. I think.
Definitely. And it helps as well for rheumatologists to be better aware of what specific aspects of disease activity or what specific manifestations of the disease they need to pay particular attention to, not only in the case of this study in terms of their prognostic value, but also which ones could potentially have the most long-term impact on patients.
Absolutely. Is there anything you want to add that you may have missed?
I think we've covered the methodology, we've covered the impact and the results of the study quite thoroughly. Perhaps one aspect that is important to emphasize is the importance of continuing to gain a better understanding of residual disease as a concept, as it is still quite new as we look towards prospects for future research. And the most important next step that we need to take is to work towards a consensus definition of what residual disease means, and to ensure that this is consistently applied both across research and clinical practice. And we hope that this study will also contribute as a stepping stone towards this objective, and is also the objective of other endeavors that we are currently undergoing in our department on the subject of residual disease and outcome measurement in axial SPA. Because as we saw illustratively, to take our project as an example, the absence of a consensus definition was an obstacle that we encountered and is also one of the most important limitations of this study, which also affects generalizability of the results and comparison of our results to other projects in other settings. And so addressing this particular knowledge gap specifically would be beneficial, and it would also hopefully help make the transition towards broader research on other prognostic factors in axial SPA, specifically also for the objective form of residual disease, seeing as in this study we mainly captured predictive factors for the subjective or the patient experienced form. So hopefully with these advancements in research in axial SPA, more research will follow, and that will hopefully lead to long-term improvements as well to the management approaches in axial SPA. And to tie this all together, perhaps to conclude with just a brief take-home message based on this study and the research that has been conducted on residual disease as a whole in axial SPA, is to emphasize that residual disease is an important and clinically relevant phenomenon in axial SPA that remains deserving of continued attention. And we hope to contribute through our results towards timely and effective recognition of this phenomenon, potentially also prediction in early stages of the disease, to enable better patient outcomes in the future, better explanations, better expectation management, informing future research projects, all with the end goal of implementing this as well in clinical practice and improving the outcomes, not only through the outcome measurements that we have right now, but also through measures that are important and significant to patients and all stakeholders.
Thank you. Well, I really want to thank both of you for taking the time to review the findings of your paper, expand upon them, and really, I think, emphasizing the importance of looking beyond the definitions of low disease activity and remission as objectively described by a physician versus patient experience, and how we can improve upon that and be more, as you've said, holistic in our treatment of our patients, because it's nice for us to say, you're doing great, and they say, no, I'm not. And I think that that's part of this take-home message, and I think that it's the beginning of future research. And to our viewers and listeners, please read the complete article titled Predictive Value of Severe Symptoms for Residual Disease After Transitioning from High to Low Disease Activity in Axial Spondyloarthritis, a longitudinal study. It's available at the journal's website, jroom.org, and in the April 2026 print edition of the journal. And I want to thank everybody for joining us, and hope you will come next month again when I speak to one of the authors of an article of particular interest in the May 2026 edition of the Journal of Rheumatology. And if you have any comments or questions, please send them to x@jroom or by email to manuscripts@jroom. And thank you.